First of all, thank you, Dr. Dispennette, for allowing us to ask you some questions. And the first question is if you could just introduce yourself and your current position and just some brief work experience.
I'm Rachel Dispennette. I work here at the University of Charleston School of Pharmacy. I am an assistant professor of pharmacy practice. I started here in July, so I'm still kind of new to all of this. I came here from CAMC. I did 2 years of residency, did a PGY1 pharmacotherapy residency at CAMC, and then I did a PGY2 specialty residency in geriatrics at CAMC. And here I am.
Thank you. And what are your strengths and weaknesses?
In general?
Yeah.
Or related to pharmacy? That's a big question. I think in regards to my current position, I'm organized. I think I would drown in work if I wasn't organized, because there's a lot going on in a professor's position. You're teaching, but in the Department of Pharmacy Practice, you also have a practice site, and so you have to manage basically 2 sets of bosses. I have Mr. Boyer, who is my department head, and then I have Dr. Brian Hodges, who is my clinical director at CAMC. And both Dr. Cook and I answer to both of those individuals. And so that can be kind of interesting, just figuring out how to manage time and who calls the shots. The answer is usually Mr. Boyer in regards to time questions. Other strengths. I care very deeply about my patients. Probably above all else. So that's when you see me in class, that tends to be what I care about most, imparting a deep care for patients. I don't care if you necessarily know something, but I want you to be able to find the answer to something and at the same time care about what happens to the patient, because that's the end of every question. That's what you're doing everything for. Weaknesses. I guess inexperience would probably be on the list somewhere, just because I'm new at this and I'm still learning how to do all this and what the structure of a school of pharmacy is from this side of things. I knew what it was like as a student, but this is a little different as a professor. So I'm still trying to find my sea legs in that regard. Other weaknesses. Sorry, I probably should have looked at these beforehand. That would have. I'm kind of hard on myself. I'm a perfectionist. Everybody says that when they come to interviews for pharmacy school. Everybody says they're a perfectionist, but I am. It's annoying sometimes. Does that answer that question fully? Did I hit every bullet?
Yes.
Okay.
Thank you. Was pharmacy your first choice? And if yes, why? If no, when and what made you decide pharmacy was your desired field?
I knew I wanted to be a pharmacist starting in high school. I took a bunch of different, free quizzes online. That sounds not very professional, but I loved science. Chemistry was very easy for me. And I knew I wanted my field to be applicable, and I wanted to be taking care of patients and doing something that was complex. And all of that put together ended up equaling pharmacy, because I feel like I'd get more chemistry if I did pharmacy as opposed to medicine, where I thought that was more biology. Whether that's true or not, you all can discern, but I ended up in pharmacy. So I did pre-pharm right from the get-go at West Virginia University, and been doing it ever since. Yeah.
Are there any problematic situations that can occur in a daily job of a pharmacist in academia and your site?
Yes, there are. The problems they can be both interconnected and different, specific to the site. In academia, you have, because there are so many moving pieces in academia, there's the dean's office, and under that falls the different departments, and I fall under pharmacy practice. And so I have everyone I work with me, and then I have my boss above me and the dean above him, and then there's the school structure, the University of Charleston structure even above that, and everybody has everybody has an opinion about how things should be run, and that's their job. And so priorities are different depending on who you talk to. And so juggling that in addition to the expectations at the practice site it's a lot sometimes. But as far as problems, most of it I think is just busyness. For instance, today I've worked on 3 different lectures, working on a poster, and then coming here to talk to you all today, and then I'm meeting with students later in the day, and then I'm taking care of something at the practice site after that. So prioritizing what is the most important is difficult, and that can really throw you a curveball. If I need to meet with X person to get this done, I have to figure out when that person's here, plus when that fits into my schedule, plus how much time it takes. It's a lot to juggle. Would you like me, do you guys want me to talk like specific things?
No, that's good.
Okay, as far as, well, I guess I should talk more about that. As far as my practice side at the hospital, that's mostly patient care related. And that's a whole other level of unpredictability, because you never know what's going to happen to a patient, because on the internal medicine service where I round with Dr. Cook, you can have 16, 18 patients, each of them in with 5 different disease states, and you have to manage the medications and all the acute issues. So you have chronic plus acute, and figuring how those all play together, plus interpreting lab values and clinical signs and symptoms. It's a lot to juggle, but it keeps you entertained.
In your opinion, what characterizes an ideal pharmacist from your point of view?
You can't get me on my soapbox. An ideal pharmacist. I think anyone that wants to be a pharmacist cannot be lackadaisical about pharmacy. And we ask students so often, what does it mean to be a professional? And pharmacy is a profession. It's not a career. And I didn't think that way in school. When I was in pharmacy school, it was just, I'm doing this, I'm going to get a job, and everybody's going to be happy with what I did. It's a respectable field. But getting into 4th year rotations and then my residency, it's a whole different ballgame. When you see patients and you make one intervention that changes something, like perhaps you catch a patient who's being discharged from the hospital on 2 different anticoagulants, and they're a 75-year-old lady who has impaired renal function, and you know if you don't do anything, that patient's going to come back in a week bleeding from somewhere. That's a big deal. And you think, oh, surely the physicians catch that. But it doesn't always happen all the time. We are just another piece of we are the drug experts, and I don't think we realize how important our role is until we actually get out there and do it. It's a big deal. We make a big difference. That sounds kind of cliche, but it's true. So I get really frustrated with people that don't care about what they do as a pharmacist. So I think you definitely have to care about your patients first and foremost. And you have to be very motivated. I think you have to be a really good self-learner also, because in school everything's given to you. Read X chapter, and you know that's 27 pages, and it has to be done by this day. And at the end you're like, I know everything. But then the day after you graduate, stuff starts to change, and there's not that person telling you what to do, what to look at anymore. And so you really have to be able to juggle all your responsibilities, plus learning all the new stuff that's coming out. So being a good self-learner and caring deeply about patients, probably the 2 I'd list.
So how do you keep up to date with current pharmacy practice issues?
That's an excellent question. You kind of, over time, develop a list of journal articles. It really should be, ideally it should be primary literature. What's the trials that are being published in recent issues of trials. There's several great websites and email listservs that provide, hey, this article came out, or this could change practice. And I'm subscribed to several of those, depending on what your practice field is. Mine is mostly focused towards acute care and internal medicine sorts of issues. And so I get the articles that are most relevant to my practice. But yeah, occasionally, however, I will just, there's several big name journals that tend to make the biggest waves as far as changing practice, and I search those regularly to see what they're churning out, to see if I'm up to date with what's going on.
What is the most difficult decision you have had to make, and how did you arrive at your conclusion?
Regards to pharmacy?
Yes.
Most difficult decision. Probably, I'd have to say whether to do a residency or not. And in retrospect, it was I would do it again, over and over and over again. Because it was tempting during my 4th year of school. I've got all this student debt, and I just want to be done learning. I feel like I know it all, but you really don't. I feel like I know it all, so I just want to be done and graduate and pay off my debt and just stop paying money to everybody I know for everything. But I went on rotations, and I knew that I wanted to do clinical pharmacy. And I loved seeing patients and working with physicians regularly. Not just, you can have a huge role in the community, but it's different than being in a hospital. And I just ate it up being in a hospital because I loved how quickly things changed and how many different balls there were to juggle. It just, however you'd like to classify my personality in regards to that is fine. But I love all those moving pieces. And so, yeah, I'd probably say whether to do a residency. And choice was well made.
Describe the time when you went above and beyond what was expected to you in regards to pharmacy, or like your pharmacy schooling.
I think I'd have to go back to my P4 rotations. And one incident that comes to mind, I was in a hospital, and I was on rotation, and you got there at 6 a.m. every morning, and you were lucky if you left by 4 or 5. And this was a 5:30, 6 o'clock day. And I was sitting with my preceptor and with another student and a resident, actually, a pharmacy resident, and I was a P4 student. And we had 2 patients assigned to us that were ours for that day. We were responsible for everything with that patient, so we had to look them up before rounds and know everything about their disease states, and we were the ones that came up with recommendations for the physician team and brought them up on rounds and suggested things. And then we were responsible for making sure those things were, after we recommended them and they were accepted, making sure that those recommendations were then implemented, as we discussed. And it was, so one of my patients was an older person. It was an older gentleman. He was in his 80s, I think. He had COPD and a heart failure and I think atrial fibrillation. And so all sorts of different multiple drugs for multiple disease states. So really a high drug burden. And he was being treated for pneumonia. And we did labs on him that day and found that, sorry, this is getting really long, but it's a good story. His serum creatinine, marker of renal function, that morning had been at his normal, which was about like 1.3. And then they did repeat labs because his urine output decreased. And at 5:30, after all the medical residents had gone home, the labs came back again. And I saw that his creatinine had bumped from 1.2, 1.3 to like 2, indicating an acute kidney injury, like acute renal failure, which is what the urine output decrease had suggested. And so my preceptor said she was leaving it up to me, but really I don't think she was. She would have done whatever needed to be done after me if I hadn't made the right decision. But she said, what are you going to do? And I said, we have to page the medical resident. And it wasn't a popular decision because that resident had already gone home and didn't want to deal with patient issues anymore. But we had this patient on antibiotics and other drugs that are renally excreted, and the doses had to be adjusted, or this patient would have shown acute toxicity, neurotoxicity, several different things that the patient was at risk of, including excess anticoagulation. So bleeding on top of confusion, and it's an older person, so you care, it's a higher level of acuity. So anyways, again, just back to patients. I love my patients, and I know I can really make a difference. patients in their drug therapy. So that's what I think of.
Alright. That's all the questions we have.
Okay.
Thank you so much.
Thank you.